Good morning, everyone. Thank you for joining us this morning for our first fully in-person Grand Rounds, and it's great to see many faces here. For those of you who don't know me, I'm Andy Cates from the Division of Cardiology, and it is my pleasure to be here this morning to introduce this morning's Grand Round speaker, Dr. Seth Martin. A couple of points as I talked this morning, though. First, and Dr. Fraser wanted me to make sure I told everybody that the coffee and bagels are coming. We don't know exactly when they'll be here, but hopefully people have some coffee in hand. And please, I was actually specifically, please don't hate the messenger here, but the coffee will be here in due time. We may not announce it till the end, though, but the coffee will be here at some point. Second, Seth is joining us this morning as part of a joint invitation from both the Division of Cardiology as well as the BJC Innovations Lab to come and talk with us specifically about the topic of digital health innovation related to cardiovascular care. Tom Maddox, who runs the BJC Innovations Lab, had invited Seth along with us. Tom couldn't be here this morning, and in his place, it's, again, as I said, my pleasure to introduce Seth. I first met Seth actually about 10 years ago. I think it was at an ACC meeting in Miami. And I think he was just joining faculty or was a senior fellow, and truly at that point had already established himself or was establishing himself as a thought leader in the prevention world. And then, as we were talking about last night, prevention was his thing, but then he was able to expand upon that and really become a significant thought leader as in the world of digital health beyond just prevention, but the implementation of technology to help improve health and prevention. So with that, and we were talking more about this at dinner last night, too, great conversation to have. Let me tell you a little bit about Seth. First, he's professor of medicine, the Division of Cardiology at Johns Hopkins, where he's a core faculty member at the Kickerone Center for Prevention of Cardiovascular Disease. And there he directs the Advanced Lipid Disorders Program and also co-directs the Digital Health Innovations Lab. Also, he serves as director of the Johns Hopkins Center for Mobile Technologies to Achieve Equity in Cardiovascular Health. That's the MTech program. And also is part of the AHA Strategically Focused Research Network on Health Technology and Innovation. He is a faculty member at the Welch Center for Prevention, Epidemiology, and Clinical Research, and also serves as chair of the AHA National Statistics Committee and president of the Maryland AHA Board. His research focuses on the intersections of digital and mobile health technology, lipidology, cardiovascular risk assessment, health equity, big data, and precision medicine. In addition to many other things that Seth does, he is co-founder of the Corey Health Digital Platform, which has been developed to re-engineer the patient and clinician experience to promote guideline-directed cardiovascular care, and we'll be hearing more about that. Seth is also a clinician, sees many patients and does a phenomenal job in implementing prevention measures in his lipid clinic. He's also published more than 300 articles in multiple leading cardiology and medicine journals, and is editor for Precision Medicine and Cardiovascular Disease Prevention. And lastly, he's associate editor for Clinical Lipidology and European Journal for Prevention and Cardiology. And beyond that, too, he's really a fantastic person. So with it, it's my pleasure to introduce Seth Martin, who will discuss digital health innovation in cardiovascular care towards equitable impact at scale. Seth?
So thank you so much, Andy, for the really generous introduction. It's a real honor to be here. Thanks to all for making it here in person. Let's see, make sure I can advance with this. So I don't know if the laser is working, but I can advance like this. So yeah, I've really have enjoyed the time here already at WashU, kind of learning. Okay, just use it at the podium. Okay.
Oh, you can use the laser on the picture.
Oh, okay. Oh, I see.
This is why they don't ask me to do this part.
Okay. It's okay. I'm good without a laser. Yeah. So yeah, thanks so much to Andy, Tom, the whole group for the invitation to be here. I had a really great day yesterday meeting folks in the Healthcare Innovation lab and just really learning from the cutting edge work you all are doing here. I'm definitely going to be taking back lessons to Baltimore. Wanted to just share some of what we've been doing in digital health innovation, with, of course, a focus on cardiovascular care and an emphasis on equity and scale. And I hope you find this information useful and it may spark a further collaboration. So my disclosures include co-founding interest in a startup company out of Hopkins, philanthropic support, research support primarily from AHA, PCORI, and NIH, and then consulting in the lipid and digital health space. These are some of my objectives. So to understand the need for new approaches to cardiovascular care delivery. Why do we really need to change the way we're doing things? Discuss the emerging role of digital health in advancing patient-centered cardiovascular care, and to recognize opportunities to address disparities in diagnosis, treatment, and prevention, and promote health equity through innovation. So a shout out to Tom Maddox, who co-authored this article, which I think really presents a great way to frame the shift that we need. So in this leadership page, they said that to date, the bulk of medical innovation has occurred in biopharmaceutical and medical technology arenas. The innovations that have emerged from these industries primarily focus on what can be done for patients diagnostically or therapeutically. By contrast, relatively little focus has been given to how innovations can be provided to their target populations and enable the care team. And so we really need, I think, this shift in thinking of how we can use all that we already have and use it better, reach our patients, and also bring back the joy in medicine in our practice. And to prop up this type of system, we also need to reward innovation. So this is a really nice policy statement that came out from AHA. Karen Joint Maddox was the senior author on this article. And it's looking at value-based payment 2.0. Central themes include finding the right balance between cost and quality. We want things that are high value interventions, but in fact, in the field of digital health, there are appearing to be some interventions that could even provide a dominant strategy, meaning that you save costs while actually improving care. Recognizing that equity is central to care, providing flexible funding for team-based care, and engaging clinicians as partners to channel internal motivation and reduce burden. Again, to bring back that joy in medicine, that we as physicians, as healthcare professionals, can help design a system that really makes sense to us and helps us do our jobs the best and best serves our patients. Why do we need a shift in thinking in terms of the delivery of care? This is just one example from, of course, throughout medicine, there's other examples, but when it comes to cardiovascular care, these are quite concerning trends. So one of the roles I have is as the chair of the AHA National Statistics Committee. So this graph that you see on the left is from our latest update. There'll be a new one coming out in January. But what we saw with cardiovascular mortality is that in both men and women, there's this decline from 2000 to 2010. And then we've seen this concerning uptrend in cardiovascular mortality from 2010 and beyond. And to some extent, this could be explained by population aging, but it's also the fact that we're just not getting the job done when it comes to using what we know to control cardiovascular risk factors. We see that in this panel on the right from a Jack paper that we published on trends in risk factor profiles among those who have established cardiovascular disease. That first blue line you see that's pretty much flat over the last 2 decades, that's a composite measure of risk factor control: diet, physical activity, diabetes, blood pressure, cholesterol, smoking, and so forth. It's been flat. Now, there's been worsening in diabetes and some improvement in other areas like cholesterol, but overall, we're just not getting the job done. And we see persistent disparities across race, and ethnicity. When it comes to cholesterol, we have seen an improvement over the decades, but I would characterize this as a fairly modest improvement, given all the tools, the armamentarium that we now have in the world of lipids. I see Ann Goldberg here. We were talking yesterday about all the new drugs that we have. There's really a robust armamentarium. And yet, when it comes to basic things, like you see on the right-hand part of the slide here, patients with ASCVD or other key risk profiles, this tremendous underuse of statins. So we're not even getting the basics of care done, let alone taking advantage of all these other new innovations we have in terms of pharmaceuticals. So I did want to just start by focusing in on cholesterol a little bit more, partly to kind of share the theme of, first of all, when we think about innovation, we need to have good data to drive our system. So when we're managing someone's cholesterol, we want to know that the data we're using to make decisions is the best possible data. So I've had this particular deep journey into the accuracy of LDL cholesterol levels, which have been front and center in trials, guidelines, daily clinical practice. This is a word cloud of our AHA-ACC guidelines, and of course, LDL cholesterol comes out front and center. It's been studied in hundreds of thousands of patients in RCTs as a primary metric that if we lower it, we lower ASCVD risk. And there's a well-established relationship, lower LDL cholesterol, 40 milligrams per deciliters, and lower relative risk of cardiovascular disease by 20-25%. That's been shown with statins and other therapies. However, when it comes to the basic assessment of LDL cholesterol levels, we have historically been an equation from the 1970s, the Friedewald equation, which we showed has this strong tendency to underestimate LDL cholesterol levels at lower levels in the modern treatment era, which could lead to undertreatment of high-risk patients. So are we making our clinical decisions based on the best data using this equation from the 1970s? Now, to its credit, this equation has served us very well over time. It works quite well in most patients, but it doesn't hold up as well in the modern treatment era. This is Dr. Friedewald pictured because his equation, his article was the most cited in the history of clinical chemistry. It's one of the top 100 medical articles of all time. I've had correspondence with Dr. Friedewald, and he had pointed out in his original paper that simple division of plasma triglycerides by 5 doesn't give a very accurate estimate of VLDL. It wasn't necessarily intended to be used the way it's used today. At the time, that inaccuracy was tolerated because we didn't have statins, we didn't have all these drugs, cholesterol levels were higher. This was a relatively smaller part of the equation that you're subtracting out, but it doesn't hold up as well in modern times. So that led us to develop a solution about a decade ago that we published in JAMA, where really the strategy we took was quite straightforward. We held the original structure of the equation, but rather than having one fixed factor of 5 to divide triglycerides, we just varied the factor because we found that the variance in the relationship of triglycerides to VLDL was really explained for the most part by triglyceride levels and non-HDL cholesterol levels. So we developed a more flexible equation, moving from a one-size-fits-all approach to a precision medicine approach, and we had access to a large, more than 1 million person data set with ultracentrifugation lipid levels. That method's now been validated around the world. It's been integrated into lab IT systems based on guideline recommendations and used now. It's been a lesson in scale because this has now been used in more than 1 billion patients by Quest Diagnostics and by other laboratories. We also, for smaller labs that don't have robust IT systems, we have a website that has a free Excel calculator that they have used, and that's been used, for example, throughout the country of Brazil. And it also was a lesson in creating a smartphone app. So we also, for those that don't have access to a lab that's using the newer method, created a smartphone app where in a matter of seconds, you can just plug in total cholesterol, HDL, triglycerides, and get the LDL out from there. So another lesson in innovation has been when you create something new, a lot of others, some folks adopt it, and a lot of others try to then do even better, which is a good thing. So there's been a proliferation of equations in the literature. We found more than 20 equations and tested these in over 5 million patients, did basic accuracy testing as well as testing across fasting status, all sorts of other clinical factors, and found that our equation still is holding up as the most accurate LDL equation to guide decisions, particularly at lower LDL levels and when triglycerides are elevated. This is a graphic among patients with ASCVD. This was a collaboration with Ty Gluckman and their health systems data. And what we are comparing is the Friedewald equation with a new equation that's come out of the NIH called the Sampson equation. as well as the equation we developed. And so what you see on the right-hand part of the slide is those with triglycerides of 100 or 50 or more, which is really where the main problem with underestimation lies. And what you see is amongst those gray and orange individuals, those are folks where the Friedewald equation would say the LDL level is less than 70, but if you use one of the newer equations, it's actually 70 or more. So that's 40 plus% of patients where actually your clinical decision could be different. You might intensify statin therapy, add ezetimibe, add a PCSK9 inhibitor in these individuals. What we find is that the Sampson NIH equation still underestimates LDL to some extent. So they only upclassify partly those, and those, whereas our equation more robustly upclassifies people. The other kind of question that's come up around here is that originally the Friedewald equation was limited to triglycerides less than 400 for the lab to calculate it. Otherwise, labs traditionally reflex to a direct chemical assay. So this is a paper that we published in collaboration with Ann Goldberg and other co-authors comparing our approach with a more extended version of our equation at higher triglyceride levels. Here, the accuracy is not quite as good as the 80–90% accuracy that we typically see at lower triglyceride levels, but still, this could be an alternative to the use of direct chemical assays and could provide an LDL result in this triglyceride range. So it's been a really interesting journey in working on something over more than a decade that's now been endorsed by guidelines in the US, Europe, Brazil, and elsewhere, but also a lesson in challenging the status quo, the equation from the 1970s, thinking about more of a precision medicine versus a one-size-fits-all approach, and really finding a way to bring something to scale. And thinking about, again, the data that inform our clinical decisions. This is just an example from cholesterol, but of course, there's examples in blood pressure, glucose, and so forth. Are we getting good data in when we make our clinical decisions? That's really fundamental to high-quality innovation. But of course, just improving the accuracy of LDL cholesterol levels is not going to fully solve the disparities and the concerning trends that we're seeing. We need innovation in the way that we deliver care. So this is an interesting example out of Boston, where they have a team-based approach using navigators and pharmacists supported by specialists to initiate and titrate lipid medications. And this is supported through technology using software to provide decision support. And what they found is that when patients entered into this implementation program, there was an increase in the use of statin therapy from 60 to 75%, increase in high-intensity statin therapy. Ezetimibe use doubled from 7 to 14, and there was a small uptick in PCSK9 inhibitor use with a reduction in LDL cholesterol levels by 24 milligrams per deciliter. So this is some encouraging findings on how we may solve for the team-based approach to really scale up what specialists can do. Not that every patient has to see a lipid specialist or a cardiologist, but that they could see a team that's overseen by those specialists. This is a little bit of an older study, but I think worth bringing up because this is one of the earliest examples in digital health of controlling lipid levels using a smartphone-based approach. So this was out of Australia, and just by sending simple text messages such as, "Do you like swimming, Clara? It's easy on the joints and very beneficial to your health." That led to a 5 milligram per deciliter lowering of LDL cholesterol. Sending messages like that repeatedly over time to patients with coronary heart disease. It's a modest effect, but yet this is another tool that we have in our toolkit to control lipid levels, to control cardiovascular risk, sending automated text messages that extend the reach that we have as physicians. So my experience in big data with the lipid analyses and now into digital health, as I'm going to talk more about, and precision health, it really gets me excited around these interesting interconnections. And this is a figure from an ACC roadmap where there's just a lot of opportunity to really build a better future of clinical care. We have a lot of now new tools that we didn't have before. But I'm going to focus in, I don't have time to get into all those little parts of that figure, but I want to hone in on digital health, which has many definitions out there. This is one that I like from the FDA. It's a concise definition that digital health is the convergence of computing power, connectivity, sensors, and software used in healthcare. And so this is a World Heart Federation roadmap for digital health that really speaks nicely to the value proposition of digital health. So empowering patients and clinicians, improving outcomes, as well as the patient experience, improving access while reducing healthcare costs. This is the promise of digital health. Now, a reason that this is an area that we may want to focus attention on as well is that our patients already are using this technology. It's such a penetrating technology in the US and around the world, the smartphone. And so if you look at individuals at risk with risk factors for cardiovascular disease or with established cardiovascular disease, the vast majority of them have a smartphone. Many are already using it to track health progress, and some are using wearable devices, and some are already sharing this information in clinic. But most are not yet sharing this information in clinic. There's kind of a bit of a divide between the consumer health use of technology and the clinical side. And we all have a chance to kind of bring these together and best leverage technology for our patients. So on the wearable side of digital health, if you're interested in kind of a deep dive into what the opportunities are here for cardiovascular care, I'm proud that one of the first residents that I worked with on research, and he's now a faculty member in cardiology, was the senior author on this Nature Review cardiology article that goes into all the different opportunities with wearables and CV care. Everything from accelerometry to PPG, ECG, giving us physical activity data, heart rate, heart rhythm data that's opening up opportunities in the world of cardiovascular disease. And I'm going to get into some of these in detail in the subsequent slides. This is happening pretty fast, but it does take time to really see tangible impacts of these opportunities. But as we think towards the future, 10 years out from now, Medicine 2032 is laid out in this article led by one of our trainees, Amir Javed, along with Francoise Marvel, who's one of the cardiologists on our team. So this is an exciting future, and I wanted to just give out a shout out. Of course, machine learning and AI is getting a lot of attention these days around large language models and so forth, which could be an exciting use of technology. For example, you could put a guideline into ChatGPT or Bard and say, please translate this guideline for a 70-year-old grandmother living in St. Louis. Help explain this. So on the patient education side and digest information, there are interesting uses that are emerging around these tools. But we also do need to be careful from a health equity standpoint. There's been examples of machine learning amplifying bias in training data sets and wearables not working as well on certain skin types. And so we need to be cognizant of this, as well as cognizant of the digital divide and access to technology. So just to give a specific example of that digital divide, this is an article on health information technology use in patients with ASCVD. So they were less likely to use technology, about half as likely compared to those without ASCVD. And as you may expect, factors such as age, education, income, employment, being married were associated with whether you're using health information technology use. So this is a clear example of disparities and the need to have targeted strategies at policy as well as hospital health system level to help address this disparity as digital health tools become part of daily practice, as they become essential tools in daily practice. On the clinician side of things, of course, the data, as I emphasized earlier, really need to be good quality data, but then they also need to become visible within our workflows, interpretable and actionable for these data to benefit our patients. And it's not a simple question of more data leading to better outcomes. I think as I first started getting into the digital health space, there's a lot of excitement around, fancy new gadgets. Look at all these data we can collect. They're going to come in and this sort of assumption that people will then get better. But it's not, in healthcare is obviously complex and can be quite challenges. So I do want to, I probably will come across mostly as, a very pro-tech, digital, future kind of person, but I do want to also be balanced and share some of the growing pains of the field. So this is one example where there was an app called the Instant Blood Pressure app, where the idea was put your phone on your chest, put your finger over your camera and light sensor, and it'll tell you your blood pressure. When we tested this formally against a traditional blood pressure monitor, we found that this was highly inaccurate. If you had a hypertensive blood pressure reading, 4 out of the 5 times it would tell you you had a normal blood pressure. So the people that were downloading this app, and it was a very popular app in the App Store, they loved it. It was telling them they had normal blood pressures. It was very well reviewed, but it's quite scary. As we look through the reviews in the App Store, patients with hypertension, heart transplants were using this app to assess their blood pressure. So ultimately, the app was taken down, but there's been other Me Too apps that have come out. So we need to be very aware of how our patients are measuring their blood pressure if they bring in a log from home. So, and although this is a cautionary tale, there's a lot of very positive data around home blood pressure assessment using traditional blood pressure Bluetooth connected monitors at home. So it's very important for us, again, to know, are the data coming in valid as we make our decisions? Just some other examples of early trial experience with tech and wearables. The IDEA trial, where young adults with overweight and obese BMIs added a wearable to a standard behavioral intervention, and there was less weight loss over 2 years. The Wired for Health study out of California that didn't show any improvement in healthcare costs or utilization. The Remind trial didn't show any improvement in adherence with a Remind device. And then the BeAT-HF trial that didn't show any benefit in terms of reducing readmissions in our heart failure population through telemonitoring with calls. So these are some failures in the digital health space, but we can learn from these failures. So let's just, for a moment, take a deeper dive into the IDEA trial, where if you look at the device that was used that did not help lead to any more weight loss, it was worn 4 hours a day because the participants found it uncomfortable. The accuracy was unclear. So during those fairly modest times that people wore it, if it was telling them that they were burning more calories than they really were, and then maybe they went and had a bigger lunch than they usually would eat, that may have blunted the response to using the wearable. So this is just a hypothesis I have. We don't really know why the trial didn't work out, but I think we can learn from some of this, as well as that the trialists did not track the use in the group of other wearables. Folks could have gone out and got other smartwatches or wearables that might have been better than the device in the trial. And since that wasn't tracked, that contamination in the control group, that also could be an issue. So we can learn from some of these prior trials. I don't have time to dive into digital health and diabetes, but I just want to acknowledge that a lot of progress has been made in the world of diabetes. And of course, CGM is becoming more and more popular in diabetes, but it's also kind of expanding, creeping into pre-diabetes and even those without. So this world of cardiometabolic medicine is of course being a very important area. So if you want a deeper dive, I do have just a reference to an article on this space, but I'm not going to have time to really get into all the details of digital health and diabetes. I wanted to mention fairly briefly as well, just heart rhythm, because this was a big deal in the world of medicine and cardiology. The Apple heart study, and now there's been a Fitbit heart study. Here, it was novel in the design that individuals that were already wearing an Apple Watch were recruited, and they were able to rapidly recruit over 400,000 people who then had their heart rhythm monitored through PPG. And there was, of course, a low number of those that had irregular heart rhythm notifications. This was a bit of a younger, healthier group. ultimately the positive predictive value of a irregular heart rhythm notification when compared to an ECG patch was 0.84. And this led to a lot of debate within the world of cardiology and medicine. What do we do with these folks that we find early in their AFib journey? What does this mean clinically? Who qualifies for anticoagulation and so forth? And there was some kind of discontent that now we're going to have a lot of folks coming in with false positive data and so forth into clinic. But the positive spin on this is that this is an opportunity to engage patients early in their healthcare journey. If someone's now more concerned about their heart health and they found that they have an irregular heart rhythm and they're found to have early AFib, that can be an entry for us to then help a younger person prevent downstream complications and so forth. But there's still open questions around how we best manage these patients. But now having the opportunity to check the ECG on a smartwatch, or also to use other digital health devices such as the LiveCore to check an ECG at home, really is opening up a more patient-centric and patient-empowered approach to heart rhythm care. In the world of EP, now this idea of burden of AFib, which can be assessed through technology over the long term more readily, is starting to kind of guide management strategies and can help guide anticoagulation, it seems, long term. So that was the Apple heart study. And I wanted to turn to some of our journey collaborating with Apple. We've had a really positive academic tech collaboration around building a cardiovascular care platform to empower patients called the CORIE app, C-O-R-R-I-E. Core is Latin for heart, which is what led us to the name. And I've had the pleasure of working with Francoise Marvel, our Matthias Lee, one of our engineers, and others on this. So basically, when I was early in my faculty journey, Francoise was doing a technology accelerator program at Hopkins, and we were working together on an initial prototype to help patients in the transition of care after a heart attack. Initially had the idea of improving adherence to dual antiplatelet therapy, and then engineers came with us on rounds and we brainstormed more and ultimately felt like we needed a larger, more holistic solution for patients. And around that time, we got on a phone call with someone from Apple, Divya, who was at Apple, and we said, what can we do to kind of collaborate, accelerate this? And she said, come out to Cupertino. So we got an Airbnb house, and Francoise and I, with our engineers, went out to Cupertino. We're collaborating with Apple, and that was kind of the original beginnings of this CORIE software. And if you want to see more details, there's a video on YouTube, from Apple's Worldwide Developer Conference that really kind of gives you a glimpse into what this collaboration looked like and the journey. But it ultimately led to CORIE, designed as a patient-centered, holistic, and engaging digital health solution for really support patients in following what we know works, guideline-based cardiovascular disease prevention. It's an app, a smartphone app paired with a smart watch. That we started on Apple's platform, we also have an Android version now. The app paired with a smartwatch with a blood pressure monitor and also data go to a clinical dashboard. The first study that we did was called the MyCore trial. So once we came back from Cupertino and worked further on the software, Francoise had interviewed patients at the bedside when they were having a heart attack, and we were bringing patient feedback into designing this software. And then when it was ready, we launched it in the MyCore trial. And so here we took patients who had had a heart attack, and we tried to get to them as early as possible in their hospital course when they were still in the CCU or our step-down unit, and downloaded this app onto their phone, or we lent a, and then they started using it and left the hospital. The goal was for them to then leave the hospital more confident and then continue to use this after. So this was, we didn't have resources for a randomized trial. This was a propensity match study using a historical control group. So what we saw were very encouraging outcomes. This was done across 4 hospitals, across Hopkins, at Harvard, and Reading Health in Pennsylvania, 2 of the hospitals from Hopkins. So we saw this really encouraging 30-day readmission rate in the CORI patients, and that connected with very high levels of engagement or activation in the CORI patients. So that readmission rate was a 52% propensity match reduction down to a 6.5% readmission rate in the CORI group, with more than 90% scores on what this measure called the PAM measure, the patient activation measure. We also formal cost effectiveness analysis that showed a really encouraging cost savings due to less readmissions. Again, getting back to that concept of the potential for digital health to lead to a dominant strategy, lower costs, improve outcomes. Another aspect of this trial was just deploying technology to older patients in the hospital. When we first started this, folks said, you're going to take this technology to a 70-year-old patient in the CCU with a heart attack. They're really going to use this. And we found that they did. Not every single one, but many wanted to use it and did really well with it. And one patient whose case report we published really highlights some of the kind of the thoughts that patients had around this. So if we had done a randomized trial, right, of a drug or something, there's only so much you can understand about the patient experience with that. But when you're using digital technology, they're using it on a daily basis, and it's helping them guide their recovery. It's really interesting to dig into what is then the patient experience with that technology. So this patient whose case report we published, she said the CORI program saved her life. She had been given the phone. She started with a clamshell phone and was given the phone as part of the trial. She quickly learned how to use it, binge watched the educational videos, and then she was asking questions of her team the next day on rounds, feeling more informed and able to engage in her care. She started tracking her steps on her watch as she did laps around the nursing station. She went home and really overhauled her risk factor profile, started cooking salmon and green beans. She got promoted at Walmart from loading trucks to a manager position. And so she really attributed this to the program, that it wasn't just the app or the technology, but it was a program that cared of her, supported by the technology. And it gave her the purpose to get off the couch. If it would have just been the usual discharge papers, that wasn't going to motivate her the same way. This was something that really connected with her. We were able to give her the loaner phone because we developed this formal iShare program to loan phones to people that didn't otherwise have one ready to go. The other aspect of her care that was really interesting is that she kind of created her own cardiac rehab program on her own. She could not go to traditional cardiac rehab because the co-payment was too much and other barriers. And when we look at cardiac rehab in general, this is a very important aspect of cardiovascular care, a very strong guideline recommendation because of the improvements in outcomes, quality of life. But yet, nationally, 20% or less of patients actually who qualify go to cardiac rehab. And there's deserts, particularly in rural, low-income communities. Even if we filled up all the spots in cardiac rehab throughout the country, only about a third to a half of patients would be able to go. And there's heterogeneity in experience and quality across programs. And on the patient side, there's the time cost to travel. Someone might have to go hours to get there. It's only Monday through Friday, and if you have to work, that doesn't work for you. And then there's the insurance co-payment, which our patient experience, as well as parking fees and so forth. So there's a lot of barriers to brick and mortar cardiac rehab. When we started looking into the literature on using digital approaches to enable more access to cardiac rehab, we found that there had been some efforts with really a strong focus on exercise and physical activity, which is central to cardiac rehab. Supervised exercise is central to cardiac rehab, but cardiac rehab programs are really defined. Their core components include much more than exercise. They're much more than a gym. It includes nutritional counseling, risk factor management, including lipid management. But we found that these other core components of cardiac rehab were being lost in digital health strategies. So we were worried that these strategies wouldn't really fully encapsulate what cardiac rehab is meant to be and what the literature has shown. So that our patients' experience and looking at the literature led us to decide to focus on expanding our technology for cardiac rehab. We successfully then competed for the AHA Health Tech and Innovation Network. And I'm really fortunate to work with all these talented folks building out this future of digitally enabled cardiac rehab. Just some pictures trying to build our spirit of collaborative creativity and synergy. It's really been an effort to bring together a lot of disciplines together, from physicians to nurses, exercise physiologists, pharmacists, engineers, the list goes, designers, the list goes on to really build this future. Our centers focus on equity, complete solutions, strengthen teamwork, and impact at scale. From an equity standpoint, I've learned a lot from my colleagues in our Center for Health Equity, that this is about giving every person an opportunity to achieve optimal health, regardless of all these different factors. And it's very different from equality. It's not a one-size-fits-all approach that everybody gets the same thing, everyone has access to the same thing, but about tailored solutions to meet people where they are and really help them solve their needs. And that's where I see technology as, because of its ability to tailor it and to iterate on the solutions, as being a really unique opportunity to address equity. The other aspect of this is that when you build technology, you can, from the ground level, as you're ideating what the features of the technology will look like, you can bring in diverse stakeholders, diverse patients into the process. So this is encompassed by this, really nicely illustrated by this quote from my colleague, Dr. Lisa Cooper, in her book, that the use of innovative technologies also makes it possible to involve underserved communities at all stages of the design, implementation, and evaluation of those interventions. So you start, such as in a room here in the AHA office in Baltimore, as shown in this picture, with diverse patients, co-ideating, co-creating what the digital health solution could look like. And this is the type of human-centered design process that we use to take the technology we had and further build it out for cardiac rehab. During the pandemic, we shifted to virtual human-centered design sessions. This is from one of the in-person sessions, though, in the AHA office. And it reminds me of this quote from Steve Jobs. You start with the customer experience, in our case, the patient experience, the clinician experience, and work backwards to the technology. It's fundamentally different approach than when I first got into the field of tech. And I think there's a lot of excitement around this tool, this tool, this tool. How can we apply it here or here? But really, to me, the approach that works best is start with the problem, deeply understand the problem, work with those who are ultimately going to be the end users, and then work back and figure out what technology is going to best serve those needs. So the process we have has been nicely described by one of our fellows, Dr. Nino Itsakadze, in this article, that, and the process in brief is defining challenges and empathizing with patients, clinicians, co-ideating, then going through virtual onboarding to the technology of virtual prototyping. And we end up with many great ideas. And then it's the process of actually ranking those ideas, which ones seem the highest yield, doing the engineering work to build them into the technology, and then testing, into piloting, and then you further iterate. It's an agile approach of then iterating. When we've done these human-centered design sessions, one of the themes that comes up again and again is we want better education, better education. Patients are going to Google and YouTube. They're craving high-quality education. And so we've invested a good amount of our efforts in actually building new educational content, text articles, as well as educational videos. We've started learning how to use a software that allows us to make animated videos. And then we interact with AI, large language models, to build the scripts for those videos. We don't just say, hey, write us the script, and then we take it. But the AI tends to have good ideas that we then incorporate into the ultimate script to really do it in a way that is most engaging and understandable for our patients. So we've taken this human-centered design process to build out our cardiac rehab program, which is designed as a program to augment existing care. I want to be very clear that we're not trying to replace brick and mortar cardiac rehab. When someone can go to brick and mortar cardiac rehab, it works really well, and we want to encourage and support that. In fact, in our original MyCore trial, rather than the usual 20-ish% of people that participate, it went up to 35, 40% of people participating in brick or mortar cardiac rehab. We want to help enable that. My understanding is that Wash U, there's actually been a navigator program that has helped improve participation in cardiac rehab, which is fantastic. We want to support that as much as possible. But then for people that can't get into brick and mortar cardiac rehab, we want an alternative solution. And that's what we've done to build out our technology-enabled program. So it's called a hybrid program because it's both the in-person and the technology. But what we find is that many patients will come in for the first in-person visit, and then they really end up doing the rest or the vast majority of sessions at home supported by technology. This world of digital cardiac rehab has become so much at the forefront that it recently garnered 2 different articles in Circulation, one of our top cardiology journals. We've been working to build in, I showed you that Text Me trial earlier. And so part of our solution is having those messages, those automated messages to congratulate, support, motivate our patients. One of the early studies we did in this field was the M-Active trial, where we took patients from our preventive cardiology clinic. We gave them a wearable on the wrist, and we were able to blind folks to whether they could see or not see their steps. So I think there was a Hawthorne effect of them knowing they're being monitored now with the wearable on the wrist. But then when we unblinded, it didn't have any significant effect. But then when we turned on automated text messages that took into account, their favorite athlete, their dog, if they had a dog, their spouse name, and so forth, and we give them a real-time exercise prescription, we found that our patients went more than a mile per day that were receiving those automated messages, had more than a mile per day of activity compared to the control group, and it was mostly aerobic activity. This has been subsequently validated, this automated text approach, in pulmonary hypertension, breast cancer, and it has ongoing testing. So, our Corey MTech rehab solution for cardiac rehab is kind of, I've mostly described it, but it is the smartphone app with the wearable, the blood pressure monitor. The app is focused on helping support exercise sessions, but not just that, understanding your meds, med adherence, tracking your vital signs, knowing when your appointments are. And then, as I emphasize, patient education, really trying to empower patients to understand what's going on. And as the data flow from exercise sessions, blood pressure results, and so forth to our clinical dashboard, the participants are meeting with our clinical coach, who's an exercise physiologist, once per week. So we're more than halfway through enrolling into this trial. So I wish I could share the results today, but we will be finishing this up soon, and we look forward to publishing the results. The overall design is shown here. We're bringing in folks who have had cardiovascular events or procedures. They're randomized to usual care versus the hybrid cardiac rehab approach. Our primary outcome is the 6-minute walk test, which is a very common test used in the cardiac rehab world, but we're looking at a number of secondary endpoints around cardiovascular risk factors. And really thankful to our fellows, Chang Kim and Isakadze, for helping lead this. These are just the diverse enrollment sites across Baltimore. So this particular trial is being done entirely within our hospital and health system. However, we're also part of a multi-center effort that's just launched to also conduct a randomized trial of digitally enabled telehealth cardiac rehab versus traditional cardiac rehab. So that's another trial to look out for, called the McNair trial. It's named after one of the patients who's on the advisory board of the trial. So this is another exciting effort underway. I'm proud of our team for the recognition from the Million Hearts group for our quality improvement initiative around cardiac rehab and the work that we've been able to advance. And one thing that I didn't have time to talk enough about is just the passion our nurses have around enrolling patients into these trials and programs and championing. Our nurses have recently taken our technology and championed it to become part of the routine care for our bypass surgery patients. And so seeing the passion of our nurses, I really enjoyed reading this article around BJC Healthcare's virtual nursing rollout. And Dr. Maddox credits the success to strong initial buy-in engagement from nursing leaders, comprehensive understanding of nursing workflows, thanks to the prior human-centered design. So we definitely share that passion for human-centered design, helping build what the clinicians or the patients will use, as well as using an agile technique where you can rapidly develop, iterate, and test the capabilities. And this was just a great quote, the sense of pride, feeling hopeful, and that change is coming. So I'm coming towards the end here. I just also wanted to mention that we have a heart failure focused collaborative project. This is also funded by the American Heart Association, where we're working with multiple other institutions on using a smartphone-based technology to help titrate guideline-directed therapy for heart failure, which has been a persistent, stubborn issue. And I'm also collaborating with Yvonne Commodore-Mensah and others from our Center for Health Equity on the linked BP trial, which is part of the AHA's Restore network, addressing social determinants to prevent hypertension. What I wanted to highlight about this linked BP trial is the model here is to pair technology with community health workers. So community health workers can be another opportunity to have that human side to help support our patients in a program to better their health together with the technology. And then finally, the ERIC study. This is a long-standing NIH-funded cohort study, and we recently received funding to link up these individuals who are 80 years and older with a Fitbit. And if all goes well, there's going to be about 800 or so individuals who wear that Fitbit over years, and we're going to be able to assess the relationship to physical and cognitive outcomes. So that brings me to the end. I wanted to emphasize that digital health innovation can help address those concerning trends in cardiovascular disease risk factors and outcomes that I shared at the beginning. And there's this potential to better serve our patients through more tailored, engaging, equitable, scalable care. As the nurses said, change is coming. The technology is here. We can either embrace it or not, but it's here, and I think it's here to stay. And so we can each shape the future of healthcare delivery as we figure out how to best use this to serve our patients. I wanted to kind of emphasize this idea of challenging the status quo, whether it's the LDL equation from the 1970s or other aspects of the way that we've traditionally delivered care, challenging that status quo and really shifting our focus of innovation from what to how. There's so much that we know works, but then we don't implement it reliably. So we really need a stronger focus on the how of care. And we need systems that will reward that innovation so that it's sustainable over the long term and that incentives are aligned to make it work. Opportunities in diagnosis around undiagnosed AFib, opportunities in treatment and prevention, physical activity, exercise, risk factor modification, cardiac rehab, as I focused on. I shared some of the studies that we've launched, but there's going to be a need for many more studies to help define, what digital health technologies really work and what is their true value. And I tried to emphasize some of the trainees that have been involved with our work because they've made such important contributions. And I think the future is bright, seeing the talent of our trainees and their dedication to this field. So thank you so much for your time and attention, and looking forward to your questions.
Thanks so much. That was a really great talk. I think we have time for a few questions. And I'll start. You showed that quote from the woman who said that, the program really saved her life. How well can you assess people's utilization of the technology just for other social engagement or education or the internet? So going from a flip phone to an iPhone opens up lots and lots of doors. So did you measure or can you look at utilization of technology in addition to the specific program?
That's a great question. We are able to track all the clicks and things that happen within our app through our backend system, but we can't necessarily track everything else that they use the phone for. But you bring in, good ideas around, for example, someone could be having more social interactions using their phone for Facebook or something. We did, for our cardiac rehab program, create a Facebook group, and they can get into that through the app so that patients can kind of connect more in that way. Something I didn't have time to really get into is this idea of kind of loneliness. I think a lot of patients, maybe particularly older patients that don't have as much family around and so forth, are part of it's an issue of loneliness. And traditional cardiac rehab, what's really special about it, one aspect is that it just brings people together, exercising together, and they see the same folks and they start having those social interactions, which is part of why we try to recreate that with the Facebook group. Of course, it's not a exact replica of what happens in traditional rehab, but you're right, it does open up other uses beyond the app. But when we talk to patients like her and others, they did emphasize that that those the certain features of the app, they felt like tracking their medications, and that the education that it helped enable. Before she binge watched our educational videos, she said she felt alone and confused lying there in the hospital bed. And so I think I've always felt that education is important, but I've come to have a deeper appreciation for how important those educational components are. And so without like a dedicated app that directs or some way of directly directing patients to high quality education, they may be using their phones to go to who knows what website on their phone or computer, and who knows the accuracy of what they're reading.
Right.
Yeah.
Thank you.
Right. Right. Yeah, I mean, transportation is definitely a big thing. That's part of the barriers to coming to traditional cardiac rehab. We do certain in our trials, and that we do address it, but I think I don't necessarily have the solution for all of clinical care. I know sometimes we give people vouchers and so forth, right, when they're going home from the hospital and so forth. But in the context of our trial, it's very important that we get people in for their trial visits, like the end of study visits. So we do pay, we have an account set up where we pay for rides for people to make sure that that's not a barrier to them participating. But I realize we have the luxury of having grant money to help pay for that, when in the real world that wouldn't be, I couldn't, if some people are coming from distances, it can be hundreds of dollars for the rides, and we don't necessarily have the ability to pay for that in care. I also recognize that as we give out phones, give out watches, we have the ability to do that because of our trial, but that access is something that in the real world, how are we going to overcome that? So my hope is that as we generate more and more knowledge around this space, that those data can help fuel changes in the ways that, in policies, in the way that hospitals, health systems, invest to support our patients. Investing in a ride or technology may end up actually being a really small investment compared to someone having tens of thousands of dollars, readmission to the hospital. But yeah, it's a great question, and I don't have all the solutions, but yeah. Yeah. Yeah, so what we do around digital literacy is that's where we have coaching. So we recognize some people are much more facile with the technology than others. So I mentioned we have an exercise physiologist who does more clinical coaching. It's impossible to prevent some of the creep of the technology. She ends up doing some of that because she's very familiar with it, and they bring those up during the calls. But we also have a dedicated technology coach that we connect people with, and sometimes they might need more than an app, and we do it remotely, but they may need more than an hour of coaching. But the digital literacy piece is important. And we also, just on the just generally on healthcare literacy, we also have been very cognizant to make sure that all of the reading material, the scripts for our videos are down at like a 6th grade or less reading level. Yeah. Right. Yeah. So we still have a lot to learn about like engagement over the long term. That original MyCore trial I presented in heart attack patients, that was 30 days. So we kind of didn't have to solve that long-term problem through that trial. Now we've extended out to cardiac rehab. And the approach we've taken was, you know, let's have the weekly coach. Now, part of the reason for the weekly coach is we're trying to mimic what would happen in traditional cardiac rehab, but that weekly coach also provides, you know, a human side to things where the patient now knows my data are going to go, unless I'm using the app and the data are going in, they're not going to have anything to see. So we found that can help kind of with engagement. But when it comes out to engagement over, you know, 1 year, 2 years, 3 years, really long term, we don't have a lot of knowledge around what that looks like within the world of kind of healthcare tech. This Fitbit study that we're doing, where we're aiming for folks to use it for years, will be a really interesting kind of learning lab around the longer term engagement aspect. But there's a lot to learn. And the final thing I'll just mention is we don't, you know, as somebody graduates from a program, if they're doing really well, it may be that they don't necessarily need to keep using the app every day. Maybe they go to a lower level frequency or even totally off. But then if things kind of, you know, happen later on and they need more attention, then they get back onto it. So I think that'll be the other thing to learn is like what intensities of engagement do people need long term?
Thank you so much.
Thank you. Thank you.
That was really good.